However, mutual discussion is not appropriate for the format of our meeting. And now it's my biggest privilege to present to you Professor Felix Sahm, who graduated from medical school in 2009 and made his first publication in 2010. And he now, at this moment, is among the world's foremost neuropathologists with over 459 publications listed in the Web of Science, 11,717 total citations, and a Web of Science H-index 64, remarkable. And he's the head of the Department of Molecular Neuropathology at the Heidelberg University Hospital in Germany. Now, I would like to give a word to my co-moderator, one of the established neuropathologists in Turkey from Acıbadem University, Ayça Erşen. Please.
Thank you, Madonna, and welcome, Felix, to our meeting online in Turkey. Felix Sahm is one of the leading actors in WHO right now. They have done a lot of work in methylation profiles of many tumors, but especially in meningiomas. He has worked in many different meningioma subtypes and meningiomas from some specific anatomical origins, and he has inspiring work for all of the neuropathologists in Turkey, and also he is very welcoming for the collaborative studies, as we also do have right now. And I am very happy to be part of this meeting, and we are very excited for listening to him, and we have a lot of questions at the end of the meeting. Thank you.
Thank you, Professor Felix. You can start screen sharing. The virtual stage is yours.
Thank you. Yeah, again, thank you very much for the invitation, and especially now, thank you for these very kind words for the introduction. Yeah, as already heard in the introduction, I will talk about meningiomas and specifically about the classification of meningiomas. So many of you, probably all of you, know that there are some changes to the classification of meningiomas since the last WHO classification, which was released in 2022, although it is called 2021 classification, but it just took us a little more until it was finally then printed. So it is factually the 2022 classification. And as said, there are many changes to different tumor types, but also to meningiomas. And besides these changes, there were a lot of other topics that we discussed about meningioma, but they not yet entered the classification. And that is also what I want to talk about today. So first, give you an update on the current classification and also the background of that. So what we discussed in the WHO group about these decisions, because the result of that you can easily read in WHO book, but I also want to give you some background of that. And then we can discuss on that, because maybe you have another opinion on these questions. And second, I give an introduction into what is currently developing in the field of meningioma and what may be upcoming markers for classification of meningiomas in the next WHO classification or in any other guidelines that may be released in the meantime. So here are briefly my potential conflict of interests for your review. And now we start right away with the current classification. So certainly every one of you has already looked into the classification, or at least into the review that David Lewis and colleagues have provided in Neuro-Oncology that lists the most important changes that are in there. And if you want, you can just now grab your cell phone and scan this QR code here to get to the publication about the summary of the classification in Neuro-Oncology. So what has changed compared to the previous classification in meningiomas? So first, there's not so much change actually. We still have these 15 subtypes. These 15 subtypes, as before, they stretch here across 9 different subtypes for grade 1. Then there are 3 subtypes for grade 2. And in the 2016 classification, it was already decided that brain invasion should be a criterion for grade 2. That was not the case before, or it was at least not clearly stated. In 2016, it clearly means that if you get a specimen in neuropathology and you see that the meningioma invades the brain anywhere under your microscopic inspection, then it should be graded as WHO grade 2 already. And then there are 3 other subtypes, and there is the first change that we want to talk about, which is that anaplastic meningioma, of course, is grade 3, but as we will see later, rhabdoid and papillary meningioma are no longer WHO grade 3. So far, if you see rhabdoid or papillary cytology under the microscope, this meningioma was automatically grade 3, irrespective of mitotic figures, of growth dynamics, and so on. And that has changed. And I also will show why that was the case and how this was debated. But first, coming to the molecular markers. And these are markers that are typically very objective. So you test them and you see them, okay, it's positive or negative or mutant or wild type. And then you can very much rely on your result and there is no inter-observer variation. And one of these criteria that is now in the classification is the third promoter status. Already in 2014, in the group from Michel Gahamarides, who is also a neurosurgeon from Paris, they found that there is an increased activity of the telomerase in recurrent high-grade meningiomas. And a few years later, in a study here from Heidelberg and with colleagues at Houston in the USA, we investigated a large cohort of meningioma and tested for mutations in the third promoter. As by that time, we already knew that melanoma, for example, can have mutations in the third promoter, glioblastoma, oligodendroglioma. So we tested that also for meningioma for the first time. And we here found that when we look at the third mutant meningioma, which is the blue line here, they have a very short progression-free survival and a very high risk of recurrence. And in fact, this risk of recurrence is higher and the progression-free survival is shorter even than the other WHO grade 3. And in this study here, there were even cases that were morphologically grade 1 among those which are the third promoter mutation. So that means, while you would have said from the microscopy, it's grade 1, the third promoter mutation clearly indicated that there will be an aggressive course, which of course is important to know. However, we knew that already in 2016, but it was not written then into the WHO classification 2016, at least not explicitly as a grading criterion. The reason for that is that this study by that time was the only one which specifically associated third status with the outcome. And so the WHO classification 2016 also said it is one study and that's not enough. So the WHO typically wants more than one study to confirm a finding of a diagnostic marker, of a grading criterion, and so on. And today we have these additional studies, actually many of them. So already right thereafter, in 2017, there were several studies which confirmed that third promoter mutant cases have a much more aggressive course than those which are not third promoter mutant. This was both the case in studies which investigated only higher grade, but also in studies which investigated all grades of meningioma. In some studies, like here from another neurosurgeon, Tarek Yuratli, they even found that not necessarily there are third mutations with single base exchanges, but there can also be structural variations, fusions, truncating fusions, and so on, which can change the activity of the third gene. And now with this additional evidence, that is enough and confirmed enough, validated enough for the WHO team, which I was part of, to enter the third status as a novel criterion into the WHO classification. So that means if there is a meningioma and it looks like grade 2, may even look like grade 1, but you find a third promoter mutation, then it is graded as WHO grade 3, because there is very consistent finding that these third promoter status confers a very unfavorable outcome in meningioma patients. Then there is another criterion, which is also new and now also used for grading of meningiomas. And actually, that's a criterion which is also now used for grading of astrocytoma, so very alike for meningioma and IDH mutant astrocytoma. And that is the status of CDKN2A, CDKN2B. In fact, already 2006 and even further before, in 2001, there were studies from Düsseldorf, from Guido Reifenberger's group, and from San Francisco, from Ari Perry, where they showed that if there was a loss of P16, the outcome was worse than if there is a balanced and retained P16. But by that time, these were not so many cases that were included, as you can see here from the steps in this plot. And therefore, it was not sufficient to use it as a grading criterion. And then one here of our team members, Philip Sievers, who is a neuropathologist, together with Thomas Hilscher, who is a biostatistician, we investigated with this team a larger cohort of meningiomas for the CDKN2A status. And there we found that, for example, when we here focus on grade 2 cases, those with a homozygous deletion have a significantly worse outcome than those which have not a homozygous deletion, so a balanced CDKN2A status. And the same is the case even within grade 3. So it's very clear that if there is a homozygous deletion of CDKN2A that confers similarly, like the third promoter mutation, an unfavorable outcome, a more aggressive clinical behavior, and therefore now CDKN2A-B homozygous deletion is also a novel grading criterion. If you find homozygous deletion of CDKN2A-B, this meningioma is grade 3, irrespective of the morphology, even if the morphology is inconspicuous. Interestingly, and that is currently a discussion that we have among neuropathologists in the C-IMPACT consortium, it is not 100% clear what a heterozygous deletion of CDKN2A-B means. So sometimes you find a case where homozygous deletion is not evident, but you still see that one copy of CDKN2A-B is lost. And we do not yet have sufficient data to call this also grade 3. It seems like, and it's also intuitive, that these are not benign, but we do not know yet if that is sufficient to really call it anaplastic. Now we have seen 2 grading criteria for highly aggressive meningioma. Of course, it would be nice if we also have criteria which clearly show us that the meningioma is benign and that there will be no recurrence, or at least a very, very low likelihood of recurrence. And at least there was some chance and some promise that AKT and SmoothNet mutations, among some others, could be these markers for very benign meningiomas. First, there was a study from 2016 from a Japanese group, and they investigated cases that had TRAF7, AKT1, KLF4, or SmoothNet mutations. And these here actually, as you know, often also occur in combination. And these cases all had no recurrences, whereas all the cases which had none of these mutations, so either NF2 or something completely different, they had worse outcome. And that, of course, is somehow suggesting that any of these mutations confers a very, very low risk of recurrence, or even no recurrence at all. Another study that we conducted together with the University of Vienna, with Anna Berghoff, Matthias Preußer, and colleagues, showed the same. So we combined all of the cases with TRAF, AKT, KLF mutations here in the yellow line, and they have better outcome, almost, not completely, but almost no recurrences than all the others which do not have any of these mutations. However, an even larger study, which was then conducted in Yale by Murat Günel's group and colleagues, they showed that there is actually some difference between these mutations. So if there is a KLF4 mutation, there's really a low risk, but if there is a TRAF7 mutation, the risk is again higher. So it is not very consistent, not very homogeneous. Therefore, it was also unclear for the WHO group to be really confident that these mutations can predict low risk of recurrence. There's still some signal that there can be recurrences, that some of these mutations behave differently than others, and therefore it was not yet sufficient data to call one of these mutations as a clear indicator of reliably grade 1 behavior. However, as you probably know, one of them, or two actually, AKT1 and SmoothNet, they can potentially be targeted with specific drugs. There are a clinical trial, or there has been a clinical trial from Priscilla Pastianos in Boston that has respective inhibitors, because she was actually also among the first who identified that these mutations at all can occur in meningioma, together with Murat Günel's group and the Victoria Clark paper. And there was also a case report from Michael Weller together with our department, where a patient with a refractory meningioma was over quite some years successfully treated with AKT1 inhibitor. But the need that the patient needed an inhibitor also shows that the AKT mutant meningiomas not always are benign, which again emphasizes that the WHO could not be confident to use this as a low-grade grading criterion. Another possible marker, also known before the current classification, is the tree methylation status at histone 3, K27. That is actually a very nice marker because we can easily stain for it. It's a very rapid test, very cheap test. And here we see two examples. Here, all the cells are positive in the nucleus for this marker, so that the tree methylation is retained in this meningioma. And here in this meningioma, the most nuclei are negative and only the vessels are positive. So the stroma cells are positive. That means the meningioma cells have lost the tree methylation here. And then we have plotted those that have retained tree methylation in black and those which have lost tree methylation here in red. And we see that among all meningioma, there's a significant difference. And when we look at the interface of grade 1 and grade 2 meningioma, which is sometimes specifically difficult to differentiate from a neuropathology perspective, it also makes a significant difference. Even more, there are some cases where within one sample, we see a biphasic pattern. So here we have on the bottom Ki67, so highly proliferating cells. On the top, we have the tree methylation. And you see that everywhere where the tree methylation is lost, like here, there is a high proliferation and vice versa. Here where there is tree methylation retained, there are very few cells stained for Ki67, so there is a lower proliferation. So that in a nutshell, in one case, very clearly shows that high proliferation goes here hand in hand with the loss of tree methylation. However, again, there was only one paper by the time the current WHO classification chapter was written, so it was not sufficient, again, to use the data for a novel grading criterion. Meanwhile, also for this example, there are additional studies. One of them is from neurosurgery in Tübingen, from Razale Tabatabai's group. They have also shown that retention of the staining has a better outcome than loss of the staining. And then a study from Gila Resade's group in Toronto. They did introduce another category, so positive, negative, and intermediary. There it was not so clear, but also a signal that a loss of tree methylation is conferring a worse outcome. Therefore, a consortium built by the International Society of Neuropathology, the IMPACT Consortium, is currently considering if we should release an intermediary guideline before the novel WHO classification that informs about the value of H3K27 tree methylation meningioma. But without giving away a secret, it seems like still the data is not robust and clear enough to use that as grading criterion, because when we analyze all meningioma, we see that those with retained status and those with loss have a significantly different outcome. But if we look into the single WHO grades, it is not so clear. For example, an obvious question would be, do the grade 1 cases, which have a loss of this tree methylation, behave like grade 2 cases? And that has not been clearly found in the cohorts that are published so far, and the cohorts are quite large. So here there are more than 1,000 cases. Here there are at least more than 100. In our cohort, there were more than 200 cases, but there is still no definite signal that can be leveraged to use the tree methylation status as a grading criterion. So still not clear enough, maybe due to the power of the studies so far, they are still too small. Another possible grading criterion, and that is specifically interesting, since that confers a very small but very distinct group of meningioma. And this is the deletion or mutation of BAP1. This was very recently found by a group from Boston. And here we have a case that was operated here in Germany, in Mannheim. And on this locus here on chromosome 3, there is the BAP1 locus, and that was deleted. And that was actually a very young woman that had this meningioma at the posterior fossa region, and it grew very rapidly and had a rhabdoid papillary morphology. So highly proliferating and very aggressive, unfortunately. And this group in Boston and other groups subsequently have identified that cases that have this deletion, the BAP1 status mutation or deletion, have worse outcome than those which have an intact BAP1. So it obviously seems that it is easier to find markers for aggressive meningioma than to find markers for reliably low-grade meningioma. But that is just as the biology seems to be in this tumor type. However, with the novel classification in 2022, we also cleaned up some of the previous subtypes that were not so clearly defined. And one of them are the rhabdoid and papillary subtype, which I already mentioned in the beginning. So due to a few studies, which were actually not that large, but quite convincing several years or decades ago, any meningioma that had a rhabdoid or papillary morphology was so far graded as WHO grade 3, because in these previous studies, they had a significantly worse outcome. However, a novel study here from Caterina Giannini and Rachel Warbel from the Mayo Clinic investigated, again, a group of cases with rhabdoid features. And they not only investigated rhabdoid features and outcome, but they also investigated if, besides the rhabdoid features, there's also something indicating a higher grade. So that is what they use here in this table. So here are the cases which by histology are compatible with grade 1 or grade 2. Here the cases which are compatible with grade 2 to grade 3. And here the cases which are clearly grade 3. And here you see if the cases are morphologically grade 1 or grade 2, irrespective of rhabdoid or not, they have a 2-year survival rate of 98% and a 5-year survival rate of 93%. Only if they also have other features of grade 3, so not only rhabdoid, but mitotic count, proliferative index, necrosis, and so on, then they have a clearly decreased 2-year and even more decreased 5-year survival. And therefore, it was then decided based on the data that cases that have rhabdoid or papillary morphology are not graded as grade 3 based on this feature alone, but that they are only graded as 2 or grade 3 if they have additional features of malignancy, like high mitotic count and all the other features that are already established. Another aspect that is very, very heavily debated, still today, it was in the WHO group, but it's still today debated, is whether brain invasion is something that should give a specific grade to a meningioma. And there are multiple studies which say the one or the other. So there are studies which say, okay, if a meningioma is otherwise benign, no features of higher grade, there can be some brain invasion, but it does not make a difference. And then vice versa, there are other studies which clearly say, okay, they can look completely inconspicuous, but if there is brain invasion, then they are aggressive. And that is also somewhat intuitively, and maybe you as neurosurgeons can tell even more about it, because if they are brain invasive, there's probably higher likelihood of a risk that there are some cells persisting in the brain after the surgery. But you know that better, so we can maybe discuss that later. So anyway, in the current classification, it is still kept that WHO grade 2 is assigned to cases that have brain invasion, or even a higher grade if they have more features of aggressiveness. But this is, we are currently conducting a large study here with several hundred cases that we have collected, and maybe then we will have a much more clearer signal than the previous studies, which were also very informative, but had not so many cases yet. Therefore, it was very clearly stated in the current classification that you should be sure that you see brain invasion. So this must be cross-totally resected, otherwise benign appearing meningiomas. And in those, it is still unclear if they really are of higher grade, but in the current classification version, it is exactly written like that. These should be graded grade 2. And then there are some totally novel developments. And one of them that is specifically interesting, it also was seen here in a specific case that we investigated and led to this discovery, is depicted here. In this case, or in these cases, but it started with one specific case, we had a young child, I think she was 5 or 6 years old, and she had a mass that was not yet known what it is in the ventricle, in the lateral ventricle. I don't know which side, but in the lateral ventricle. And the operation was done, and one suspicion was, of course, maybe ependymoma because it was in the ventricle, but it didn't look like that. And the immunohistochemistry actually indicated it could be meningioma because it was positive for the somatostatin receptor 2A. EMA was also at least weakly positive. And then when you have a young child with a meningioma, you typically think of neurofibromatosis type 2, of course. And we investigated that, but it was negative. It was no NF2 alteration, but we performed also the methylation analysis, and we found that this case fell exactly like the other meningiomas in the group of typical meningioma cases. And also the score of the methylation classifier revealed a clear indication of meningioma as the highest prediction. But what was the alteration in this meningioma if it wasn't NF2? So we did not only DNA sequencing, we did also RNA sequencing. And this RNA sequencing revealed that there was a fusion of the gene YAP1 on chromosome 11 and MAML2 on chromosome 11. Actually, that also can happen in epigeneoma, but it was clearly morphologically and epigenetically not an epigeneoma. But that it can happen in epigeneoma makes perfect sense, because these YAP alterations exactly feed into the same pathway as NF2 alterations. It's just another side of the same pathway, of the Hippo pathway. And therefore, it is fully understandable, and in this case here proven, that YAP1 alterations like this fusion can give rise to meningioma. And we then investigated some more cases of young children and also younger adolescents that had meningioma without an identified driver. We performed this RNA sequencing, and we found several other cases that had this YAP fusion. And meanwhile, Eric Holland in New York even developed an in vivo model of YAP1 fusion positive mice, and they also developed this type of meningioma. So very, very consistent data that shows that YAP1 is a novel, previously unknown driver of meningioma development. So here's now summarized what the new WHO classification gives on information on the grading and identification of meningioma. And that is just an example here for the structure of the new WHO classification book. Every chapter of the classification now has these tables, because typically in diagnostics, or if you just want to get some information on a specific tumor type, you have to read all of the pages and to see what all the different aspects are in the different paragraphs and chapters and so on. And here it was then suggested by the WHO team to have a clear-cut table in which the fundamental information is captured and clearly summarized. And that is always in the same structure. You have essential diagnostic criteria. So you really need to have those to make the diagnosis. And there are some desirable diagnostic criteria, which can be an assisting adjunct if the essential diagnostic criteria are maybe not met, or which can provide some more subtyping in addition to the essential criteria. And for meningioma, the main essential criterion is still the morphology. So because we have a few markers seen in the first part of the presentation, but not every subtype is diagnosed by a molecular alteration. Actually, only a few have molecular alterations that feed into the classification. Or alternatively, if the morphology is compatible but not fully convincing, you can also look for the typical alterations of NF2 or any of the other genes that are frequently found to be mutant in meningioma. Also, for example, SMARCA1 in clear cell, or the BAP1, which I have just shown before. Or as a third layer, and that is also something that is new in the entire classification, nearly in every chapter, you can also use DNA methylation for meningioma identification, and I will come to that into a minute. Desirable diagnostic criteria are not so interesting here. It is dual or meningeal localization, which is obvious, staining for EMA or SSTR2A, and classic copy number alterations, which we will also discuss in a moment more in detail. But still, the main challenge in meningioma assessment is not to identify if it is a meningioma or not. That is typically easy. The main challenge is really to identify for the individual patient how the outcome will be. And if you do not find these very obvious changes like TERT or CDKN2A deletion, you still do not know for sure if this is a very benign meningioma or if there is a risk of recurrence or regrowth. And that is because there are so far no really reliable and widely applicable markers besides the mitotic count. And if you assess the mitotic count in a sample of a meningioma like that, where we have 4 different sections, you can, of course, depending on where you look, you can find 4 mitotic figures. You can also maybe find 6. And this can be compatible with grade 1 or with grade 2. And so 2 different neuropathologists in the different sections that are possible of one of the and the same case can come up with different grading of a meningioma. And even the same neuropathologist looking at 2 different sides of a case can come up with 2 different grading results. And that is, of course, an issue that we want to overcome to have the grading more precise and more objective. And for that purpose, we have used DNA methylation profiling. And that was already published in 2016. So I will introduce that only very, very briefly, because if you are interested in meningioma, you may even know that already. So we have investigated a large cohort of almost 500 meningioma with DNA methylation arrays and found that they cluster into 6 subclasses. And the subclasses had very different outcomes. So 1, or actually 3 of these classes had a very favorable outcome, 2 had an intermediary outcome, and 1 had a highly aggressive outcome here. And therefore, we give them also respective names. So 1 is the methylation class benign 1, benign 2, and benign 3. Then we have 2 intermediate classes, intermediate A and intermediate B. And the aggressive one we called methylation class malignant. And they not only were in different methylation classes by clustering on a t-SNE or UMA plot, they also had differences in other characteristics, like in mutations, in copy number, in morphology, in biological sex, and in localization. So we see that here that the BEN1 cases have typically only NF2 mutations and only a 22q deletion. On the other side of the spectrum, we have also NF2 mutations, but many additional alterations, TERT mutations, for example, many chromosomal alterations like 1p loss, 10, CDKN2A deletion. And then between, you can have the intermediate cases which have some, but not all of these alterations. And then there are totally other cases like the benign 2 group, which has no NF2 alterations, but instead TRAF7, KLF4, smoothened AKT1. And yet another group, benign 3 cases, of no mutation at all, but chromosomal gains, especially of chromosome 5. They all can occur on different sides of the, different side of the brain. But one of them, the benign 2 group here with the AKT mutations and so on, they also typically can arise on the skull base. So has this entered now WHO classification? Well, a little, not completely, but a little it is at least mentioned. But again, there was by that time only this one DNA methylation study. And actually, there was not only one, but only one that proposed these subgroups. There was another one from Adriana Ola, and another, actually even more, from Andrew Gao before, which also introduced different sites or different subgroups based on methylation. But there was no consistent methylation subtyping and subgrouping yet when the novel classification was discussed. And meanwhile, our group, together with our guest researcher from Utrecht and Leiden, Nick Maas, we have had a follow-up study. And we included more than 3,000 meningioma samples. So some were primary recurrent. So these were 2,868 individual patients, which were included, and of all of which we performed methylation analysis. So that was really quite a large data set. And they came from all over, well, not all over, but from many sides of the world, many, of course, from Europe, but also North America, South America, and so on. And of 985 of these cases, we not only had molecular data, but we had also clinical data, so outcome data. And these were split in a discovery cohort retrospectively and 2 validation cohort, again, 1 retrospective and 1 even prospective. So prospective means that after the publication I had shown in the previous slide, our colleagues on different sites around the world have used this methylation analysis, and they have already implemented into their diagnostic reports. And therefore, then we had prospective data where analysis was done with methylation, and the patients were then prospectively observed and monitored for the outcome, comparing the WHO morphology grading and the novel proposed molecular grading by methylation. But when we then analyzed this data of more than 3,000 cases, it became obvious that methylation is very powerful, but there is so much other information that is also very important and powerful for meningioma grading that we should not just leave that unused. And we should also use that for making the diagnosis and the prognostication even more precise. And therefore, we devised an integrated model that not only uses methylation, it also uses the morphology analysis, the WHO grading, which has evolved over nearly a century, since Bailey and Cushing actually. We also use the methylation family, which are relatively new. And we also, as a third layer, use the chromosomal alterations, which are also around in meningioma research since several decades. And all of this different information receives a specific score. So for example, if you have grade 1 morphology, 0. If you have grade 3, 2. If you have a benign methylation class, again 0. If you have malignant, then 4. Few or none copy number alterations, 0, 3 or more, a score of 3. Then you add them up and you come up here with a respective score that indicates a low, intermediate, or high risk of recurrence for this individual case. And this integrated model indeed performs quite well. So we get 3 very distinct, statistically very different outcome groups. And specifically, and that is important for the daily diagnostic process in neuropathology, we can very nicely now differentiate cases that are at the borderline between WHO grade 1 and WHO grade 2. Because typically in diagnostic practice in neuropathology, it is not difficult to identify an anaplastic meningioma. Maybe you already see it during surgery that it is anaplastic and somehow is different from other meningiomas. You can even maybe at least imagine that from the MR imaging that there is maybe a more aggressive growth. But between grade 1 and grade 2, that is the real challenge in diagnostic practice. And therefore, we specifically interrogated how this score can help us in making this differentiation. And we here quite nicely see in black those cases which are the average WHO grade 1 in our cohort, and in yellow, those outcome of the average WHO grade 2 in our cohort. And here in yellow dotted are those cases which by morphology, so by current WHO grading, have a WHO grade 2 assigned, but based on our integrated risk score, have a low risk. And as you see, they are similar or even better than the average WHO grade 1. So we can clearly single out cases which look higher grade, but actually behave low grade. And vice versa, you can already imagine what then this line here is. So the dotted line in black are those cases which by morphology are grade 1, but by the integrated score have a higher risk of recurrence. And they are indistinguishable from the WHO grade 2 cases here. So again, a case that looks inconspicuous, but will have a higher likelihood of recurrence, faster growth, can be identified here with this integrated score. And now many people, of course, with good reason ask, okay, should we do meningioma analysis or methylation analysis of every single meningioma? That may become quite expensive, which is true. We also don't do that. We also do it for selected cases only, for example, for young patients or unclear patients, unclear cases. And also when we assessed our data, it became apparent that some cases and some subtypes do not need this analysis. For example, here, the secretory meningioma, they are always in the low risk group. Angiomatous meningioma, always low. Pseudomatous, always low. The clear cell meningioma, always intermediate risk. So that means if you have these histologies, you do not need to do additional analysis. And you can, of course, but you don't necessarily need to, because these always fall into the same group that you can already predict without doing this methylation analysis or any other molecular typing. And based on this insight, we devised an algorithm which should be most efficient and also especially cost and time efficient to come up with the most precise diagnosis for an individual meningioma patient. So first, we look at the histology. And as I have just shown, if it is angiomatous, pseudomatous, or secretory, it is low risk. And if it is clear cell, it is intermediate risk. So these are already out, these are solved. If there is any of the other histologies, then you need an additional molecular risk stratification. And I will zoom in here a little. So we have 3 different options. And we have devised these 3 different options because depending on the laboratory, you may have one or the other technology available, or you maybe have all available, but just for your lab workflow, you use typically more one or the other. So therefore, we propose here these 3 different options, which have a different predictive power. So the highest predictive power is if you use the methylation array, because then you have a methylation score and you have a CNV plot, which comes out of the methylation array just as a byproduct automatically. And you can then calculate the integrated risk model, which I have just introduced before with these numbers that you sum up and so on. And then you get clearly cases that are low or intermediate or high risk. Alternatively, here is option 2, if you do not want or do not have methylation array at hand. You can do like traditional analysis like fluorescence in situ hybridization or other single copy number alteration assays, and first investigate the 1p status. Because we found that 1p is the most decisive copy number loss for prognosis, and also the most abundantly altered chromosome besides NF2 or 22q. If there is 1p balance, then it indicates a low risk. There are a few cases of high risk with 1p balance, but these are very, very few exceptions. So if there is 1p balance, it's typically low risk. If there is a 1p loss, it may belong to a higher risk group, or most likely belongs to a higher risk group. And you can either do analysis of TERT or CDKN2AB, as the WHO classification now also mandates that, to identify the really high-grade cases. Or you can look for the next most frequent chromosomal alterations that are associated with outcome, which are 6q and 14q loss. So if you have 2 of these losses, it is indicative for high risk. If you have only up to 1 of this, it is indicative for intermediate risk. So that means also without the methylation array, just with a few single chromosomes tested, you can also have an immense increase in the accuracy of risk prediction. And third, you can also perform a targeted gene analysis for the genes that are typically mutant in meningioma, like TERT, or for the copy number of single genes like CDKN2AB. And if there is an alteration of TERT or CDKN2AB, it is high risk, as I've already shown very in the beginning of the talk. And if there is an alteration of TRAF7 or KLF4, it is likely, but not so sure, based on current data, that there is a lower risk. And if these all do not work out or are inconclusive, then you can go with this or this option in addition. The next question, of course, that many people ask, and that is a very justified question, is what difference makes that? Is that like academically relevant, or is that really making a difference in clinical practice? And that is a very valid and important question. And therefore, we investigated that here in our cohort and just representatively picked 100 cases. So if we had 100 cases of WHO grade 1 meningiomas, so these patients here, 100, all have WHO grade 1 histology diagnosis, then our integrated risk prediction turns out for about a quarter of them to have a higher risk of recurrence. And in fact, it turns out to be true that a quarter of them has this higher risk of recurrence. And among the grade 2 cases, also roughly about a quarter turn out to have a better outcome than grade 2. And about a quarter turn out to have an outcome almost like anaplastic meningioma. And again, while they cannot be identified by WHO grading alone, the integrated score can identify these which have a lower and these which have a higher risk than the morphology indicates. And for grade 3 cases, as I already mentioned before, these are typically very obvious, so there is not much mistake in these. But even there are a few cases that turn out to be less aggressive than the morphology would indicate. Now I've talked some about our approach to meningioma grading, but there are also other very, very interesting approaches, and one of them is from the Toronto group, from Gila Rezadeh, here published by Farshad Naziri as first author. And they propose 4 different subgroups, which are based on methylation, but also based on mutations and RNA characteristics, very similar to what I have shown you from the other subgroups. So there's one subgroup that has a lot of NF2 alterations, which is indicated here, so the red ones here. The higher aggressive, more aggressive cases also have NF2 alterations. Then there is one group which has rarely NF2 alterations, but therefore instead TRAF7, AKT1, and so on. So this is another approach of subgrouping, not 6 subgroups, but 4 subgroups. And they also show a very, very distinct outcome here in these 4 subgroups at an increase of precision compared to the WHO classification. And another approach, technically very similar, also using mainly methylation, but also adding copy number information and some pathway investigations, is this here from David Raleigh's lab at UCSF. They find 3 different subgroups. One of them is Merlin intact, so that is what we would call the benign 2, or also the Toronto group would call Merlin intact or non-NF2. An immunogenic group, which is the one we would call benign 1, or the Toronto group would also call immunogenic or immune enriched. and one group that is hypermitotic or hyperproliferative, or in our system, the malignant group. So there are not total overlaps between these different approaches, but they are quite similar. And now our current task for the neuropathology, neuro-oncology, neurosurgery community would be to unify these three very similar, but not 100% identical approaches to meningioma grading, and to come up with an integrated approach that uniformly captures this important data that was here published in several interesting publications, and to come up with something that is really in a daily practice applicable to make meningioma diagnostics more precise, but also more accessible, not only limited to those who can do high throughput profiling on every single meningioma sample. And that is exactly what I want to close the talk with, the question how we reduce the complexity of the molecular workup. Because we see that here in our lab, and it's probably the same for your lab or for the neuropathologists you are working with, and that you are waiting for the reports that they send to you. It takes quite a while until all these analyses are done, and it costs quite some money until all these analyses are done. So both on a sample basis, but also the equipment that you first need to run all these analyses. So typically for a paraffin sample or also a frozen sample, you may want to do array scanning for DNA methylation. You want to do next generation sequencing for mutations. You want to do also RNA analysis in some cases for fusion detection. And that takes quite a while and needs quite some devices. So we have then set up here a workflow that uses a very, very tiny nanopore device, which is not exactly the same format, but the same weight and footprint to, like, for example, a cell phone or a larger USB stick or so. And we use a neural network to leverage the data coming from this very small device to get you all of the layers that you get out of the diagnostic procedures up here. And I can show you how that works, because we used one specific trick that this technology, the nanopore sequencing technology, allows us to employ. So when we put the DNA on a nanopore device, it goes through such a nanopore, which obviously is the which coined the name of this device, a small pore, which is then a nanopore. So in this nanopore, the DNA is entering, and it is pulled through this nanopore. And what we are doing now in our modified workflow is that during it is being pulled through this membrane and nanopore, we are already identifying what DNA fragment it is. So really in real time, when it is being sequenced, not afterwards, but during being sequenced. And that allows us to identify if there is currently an interesting DNA fragment in the pore. So for example, if it is an IDH fragment for glioma diagnostics, would be interesting. If it is MGMT for methylation, would be interesting. If it is NF2 for meningioma, would be interesting. If it is any other gene not related to brain tumors, is not interesting, and then it can be ejected. So it is ejected from the pore and not further sequenced. That means we do not need to do any library preparation before. We do not need to enrich for the genes that are of interest for brain tumor diagnostics. We just enter an Excel table to the computer that is attached to the sequencer, in which we state the genes we want to analyze. And if the gene of interest is in the pore, it gets sequenced. And if it identifies to be a gene that is not relevant, it is ejected. And so we have an on-the-go real-time enrichment for the regions of interest. That is something that was here in the lab devised by two students, two doctoral students, Ariba Patel and Hirin Dogan, who have set this up. And we have also filed that for patent. And we are now readily using that in diagnostics, and also have many other collaboration partners which are using that on a regular basis. This is here the actual setup. So here's the laptop, and this is the sequencer. The sticker is not on the sequencer. That is just a joke that made in the lab, but you see the size of the sequencer. So you can really put one sample at a time on the sequencer and get all the information that you need for brain tumor diagnostics. We have published it here in a proof of concept study. And instead of splitting the DNA in one part for the mutational analysis and in another part for the methylation array, we put them all on this one single device. and we get all the information we need. In this study, it was about glioma, so IDH status, TERT status, 1P, 19Q, 7, 10, 19, 20, EGFR, CDKN2A, MGMT, and the methylation prediction. And that is not only an advantage that you have only a single device and a single assay that you have to run, you also have the advantage that you can run every single case at once. So that does mean you do not have to batch like 8 different cases for methylation analysis, because you otherwise would waste the chip, because it takes only 8 or multiples of 8. So you can instantly, when you, for example, get the frozen section, and that is what we are doing here, and when you get the frozen section, you can put it on this device and immediately start sequencing, and you have, in the current version of the protocol, a result the next day. And in a version of the protocol that we are currently working on, we even strive to get a result even within the surgery procedure, so within only 20 or 30 minutes. This is what comes out of it, a really full-fledged report, a diagnostic grade report that we would also get with NGS, with methylation profiling on this array and so on. So if I zoom in here a little, we get mutational analysis, even for TERT, which is very difficult to sequence since it is in the intron, the promoter alteration. We get the copy number plot here, for example, 7 gain, 10 loss, and the combination of TERT mutation, 7 gain and 10 loss is already very pathognomonic for glioblastoma. And indeed, the methylation classification also indicates that it is a glioblastoma, all out of one very small device, out of one run, and with a very low footprint and very efficient analysis. So that as an outlook on the technical side, how we can actually assess all of these different parameters that we will soon need based on the novel guidelines for classification. And at the end, I want to thank all of the collaboration partners which were involved in the study from our group that I have introduced. But there are also, as you have seen, many other important studies from different groups around the world that I mentioned that I very much appreciate. And of course, I appreciate and thank you for your attention and look forward to a very interesting discussion with you. Thank you.
Thank you very much, Professor, for your very interesting and comprehensive lecture. I see the chat is not as active, but it is understandable because majority of the audience is neurosurgeons, but we have a neuropathologist with us. I would like for them to come forward and ask questions. Before, I have one question of my own. So as a clinician, I was wondering, what is the role of those molecular biomarkers in decision-making during the treatment? For example, after the surgery and the presence of residual tumor, would it be essential in deciding the radiotherapy or other adjuvant, I would say, treatments? What do you think?
Yeah.
Are there any research in this field, or do you have any information regarding this?
Yeah, that's of course a very important question. So from several radio oncologists that we are working with and that are sending their samples to us, I know that there are typically cases where the morphology report, the grading for grade 1 or grade 2, and the presentation of the patient in terms of imaging or in terms of symptoms do not really fit together. So they suspect that the tumor may be more or less aggressive than the histology report indicates. And so they want to have additional input to advise the patient if radiotherapy is needed or not. And that is when they ask for this additional analysis. And then together with the patient, they investigate if the additional data indicates a higher or lower risk of recurrence. And that can then indeed, on a single case basis, be one of the different parameters that are the basis to decide for or against radiotherapy.
Thank you so much. Professor Ayça,
Thank you very much, Felix. So I have, as I told you, many questions. Maybe some of my colleagues also will ask some of these questions, but I will start. So in WHO classification of meningiomas, it's a little bit different from the glioma chapters, diffuse glioma chapters. We feel a lot of question marks in meningioma chapter. So the histone K2N7 methylation immunohistochemical stain is a question mark in the chapter, and you also mentioned about it. Brain invasion is a question mark in WHO classification. Bone invasion is also another question mark. And in the classification, you say third mutation and CDKN2A deletion is enough for grading as 3. But now in the diagnostic algorithm, you suggest you first advise to do 1P deletion analysis. And this is also not clearly mentioned in the WHO classification. So actually, we have a lot of meningioma cases, more than 200 cases a year. And I started doing histone 3 K2N7 methylation immunohistochemical stain since the paper you wrote in 2018. And it helped me for a very few cases. And I then started doing third mutation analysis, and in 300 cases, I had only 2 cases with third mutation. But when I started looking for copy number variation, I had many cases with copy number variations. So, and many of them, especially for 1P deletion, had recurrences that we did not expect from just looking at the histology. So I started doing array CGH for the whole genome copy number variations in meningiomas. And now we pay much more for that in deciding for the tumors which have to be more closely followed up, or additional adjuvant radiotherapy, because the neurosurgeons and neuro-oncologists ask whether they should radiate or not radiate the patient. So grade 2, just based on histology, is not enough for giving a final decision for that. So what do you think about the chapter in the WHO? And what do you think? Do you think the copy number? Yeah, if we had an ability to do methylation analysis, it would be very nice, but we do not have it in Turkey, so we cannot do it. And doing NGS for every meningioma patient is very expensive. So we chose to do just copy number variation analysis for the patients, and it really works well. What do you think about it?
Yeah, these are a lot of very, very interesting and important points. So maybe one by one. So I think one of the first you mentioned is the trimethylation, right? So that is exactly what we also see. So from all the studies, and even if we combine all the studies, there are few cases that have this trimethylation loss. And since there are so few cases, it is a good question if that makes sense to test that, because in practice, you need to do it like 12 weeks to find one case, right? And this is also the reason why statistically there is still no clear signal if that is relevant or not, because if you have so few cases, then the groups are very small, and if you test that, you do not get a significant result. So therefore, it matched perfectly with what you described. That is the same as we have also seen in others' data, and that is why there is not enough evidence, because there are so few cases that are negative, to have that as a grading criterion in WHO classification. So that fits pretty much in your department as it is for all the others. The second part is with the copy number. So that is something that also surprises me, because there are many papers from around the world. There is one group, for example, in Spain, which has published a lot about copy number already 10, 20 years ago. And they've all again and again found that copy numbers are so relevant for the prognosis in meningioma. And also in, at least I tried always in our paper to cite these, and I think I also have that because that is really valuable research that has been done over decades. But in the WHO classification, we discussed that, and there were many other partners in the WHO team that said, yeah, well, there are many associative studies which say it's relevant, but they do not have really data that show which of those is relevant. And therefore, we have now undertaken an effort to look specifically at 1P, because there are papers that say 14Q is relevant, others say 10P is relevant, others say 1Q, but there's no unified approach where someone says, okay, I look only at 1P in 2,000 cases, and then it's really solid and robust. And that is what is now being tried. And then I'm pretty sure that 1P deletion will become a grading criterion, and that this will be a grading criterion that is much more applicable in a daily practice than all of the others, because it just happens much more often.
Yeah.
For the TERT and CDKN2A, that is also something that we are thinking of, and we are just in the process of writing a follow-up paper on a classification that gives information when it makes sense to test for TERT and CDKN2A, because that is not written in the classification, right? It's just can do it, can also not do it. As you said, it is maybe 1 in 150 meningioma or so that has these alterations. So that is somehow a fine line. I mean, on the one hand, we know it makes a difference, so we could not keep it out of the classification, right? But on the other hand, it's also understandable that many people, also we here in our diagnostic practice, say, okay, we know this is a marker, but it's a marker that we rarely see. Yeah, it's exactly the same. So therefore, sure, we could not say it's irrelevant because it is proven to be relevant, but I can completely understand, and as said, it's the same for us. It is very rarely relevant because you very rarely find it.
Yeah. Yeah. And also for brain invasion and bone invasion.
Yeah, that is, I'm not aware of many papers for bone invasion. That's a good question, but that is maybe also because the bone invasive tissue, at least in Germany, is often not sent to neuropathology. So not inspect that. But for the brain invasion, there are, like every half a year, there is a paper that says one or the other. So that is really difficult to judge on that, because these papers on an individual basis, they are completely solid and understandable, and that is very nice design and work, but they come up with totally different results. So you have seen them, of course. There are papers which say brain invasion is a clear, distinct criterion, and others that say, no, it makes no difference. And I suspect, and that is also what Ari Perry from UCSF, who has introduced this criterion initially, what Ari Perry says, it may be that some tend to give the finding of brain in the specimen more easily as brain invasion than others. So for example, I mean, you know that also there may be some people which are not experts in neuropathology, but do pathology and some neuropathology cases just by sight. They may, for example, confuse the Virchow-Robin spaces with a brain invasion or so. And then you come up with totally different results. So
also, many people do not process the whole tissue.
Right.
Yeah.
That's a good point.
So, yeah, I started processing the whole tissue in 2018 in Acıbadem, and we found a lot of brain invasive meningiomas. And our grade 2 meningioma incidence got very high frequency afterwards.
I see. Do you have them still? Could you do some further investigation in them? Because
yes, we are working on it. I think we will publish it very soon.
Excellent, excellent.
And I understand for bone invasion that I couldn't understand why the neurosurgeons do not send you the bone part of it, because in Turkey they send every part of the surgical material to us. And now I understand why you referred a 1999 paper for bone invasion in WHO.
Yeah.
Okay, so we can ask for questions from the audience.
Yes, I think someone raised their hand. I don't see them right now. Servet,
I think he.
it was an
changed his
accident.
mind.
Okay. Okay. Professor Bektaş Açıkgöz, do you have any comments or questions?
Thank you very much, Professor, for your nice presentation. I had a middle-aged woman. I removed a tuberculum cella meningioma, and there was no recurrence. But in the same patient, I removed meningioma in the CP angle, from the CP angle, and it recurred 16 times. We had done radiation, but we didn't succeed in that patient. I couldn't be able to do 17th operation because she died because of lung failure. And we examined all the specimen with experts in Turkey, but unfortunately we didn't have the examinations you have done.
Unfortunately, even with the examinations that we do, we often find information on the diagnosis or prognosis, but we rarely in meningioma find a treatment target. So that is really a difficulty. So all these alterations, copy number, NF2 mutation, there is only for very few of them, like AKT and SMO mutation, there is a treatment. And that is somehow the downside of this molecular analysis for meningioma, a little bit like in glioma, that we know a lot, but we cannot really treat it then, despite this knowledge, right?
Mm-hmm. Thank you. Thank you.
Thank you.
I would have a question for you, as there are so many neurosurgeons, because that is something that, depending on whom I'm asked, I get different replies. So if we had a molecular diagnosis already in the intraoperative frozen section, would that be important for you at all, or would that not make a difference because you want to know, okay, if it is glioma, lymphoma, meningioma, metastasis, but you do not know anything beyond that in terms of molecular information, or would you make a difference then in the surgery?
Yes, it is very helpful for us. Thank you. It's
Okay.
very helpful.
You mean during the surgery or
Yes,
after the?
During.
Yeah.
During. Yeah, I guess it would make a difference. Kamil Ojad, what do you think?
It makes difference, of course. First of all, the planning of the surgery. We try to remove all the meningioma and then to inform the family and the patient to guess a recurrence or something like that.
I think also in planning, like planning how radical the surgery should be, the margins, and I think in case of invasion, I think that will be really important. And I see one question, thank you, from Asli Jakir. What should be the grading of tumors with a sinonasal invasion or meningiomas where most of the tumor is in the sinonasal region?
Well, that's a good question. So I think I cannot generally answer that. Would then still depend on the individual sample, how that looks, if the proliferative activity is there high or low. And as we just heard, on the 1P status, for example, so that is certainly something that gives information on that. However, in the sinonasal area, there may be some chance that it actually is not NF2 altered and also not copy number altered, but maybe one of these AKT, PIK3CA, and so on altered. But that needs to be analyzed, of course. It may be, but is certainly not granted before evaluation. And depending on these markers, especially, of course, mitotic count and so on, then it would be graded. And from the localization and invasion alone, you could mostly not infer the ultimate grade already. So you have to look into it in detail.
Thank you. And I have a question. What about the spinal meningiomas? Did your study only include the brain meningiomas, like the cranial ones, or like on
That's a good question. Yeah, they included also spinal meningiomas, but there were not so many, and they mostly were two different types. So either it is pseudomatous meningioma, which were then mostly of elderly women in the thoracic area, and they were really, really full of these pseudoma bodies and very, very hard and calcified. That's the one type, and the other type is more in younger patients, not necessarily children, but adolescents and young adults. And these are the meningiomas which are SMARCA1 altered. That can be germline, but that can also be somatic. And they have then typically clear cell morphology and unfortunately also higher risk of recurrence.
Thank you so much. Professor Aisha?
Yeah. So I have two questions about the treatment of meningiomas. You mentioned about some targeted treatments based on the mutations of the meningiomas, but we get a lot of questions from neuro-oncologists asking if this tumor is somatostatin receptor 2A positive. And they decide on giving somatostatin receptor inhibitors on these tumors when we report the tumor as positive. But we know it is a diagnostic tool, so we expect all the tumors to be positive. So there are some papers that the expression extension and the expression strength differs in some tumors, so it can be predictive for the response for somatostatin receptor 2A inhibitors. This is the first question, and the other question is there are some also studies indicating that third mutant meningiomas are radio-resistant tumors. So we say it is third mutant, then we say it will recur, and then in the the clinician, what can they do? They can just give radiation treatment. And if it is radio resistant, then it makes no sense. So this is the second question. Thank you.
Yeah, these are good questions. So maybe we start with the second question. I'm not 100% sure, but maybe I do not know the data enough to know that if the third mutant cases are really radio resistant, they are certainly aggressive, but I'm not sure if they are so aggressive that they grow despite radiation, or that the radiation does not make a difference. So maybe they grow even faster without radiation, but maybe it makes no difference. I don't know that. So maybe the radio-oncologists know that, or maybe that's already anywhere published and I'm just not aware of, which of course would be a shortcoming, so I should read that. But I'm not 100% aware that this radio resistance in terms of not making a difference is already firmly established, but I may be wrong. Maybe I just don't know that. The first question was for the somatostatin receptor, right? That is something that here in the hospitals that we are working with is practically not done at all. And therefore, I can't tell from our experience here, but I know from Munich, where Jörg Tonn was until recently, I think he just recently retired, but where he was head of department, that they really, really frequently use DOTATOC and DOTATATE treatment, and they will have more experience with that. So we are using that purely for diagnostics, and I'm not aware of our nuclear medicine or radio-oncology department of using respective treatments there. Therefore, I know that also only from the literature, but not from any experience that I could share.
Okay, thank you.
And I see one comment from Shahpur Shirzada from New Vision University in Georgia. The use of this nanopore sequencing tool during the surgery will change the whole dynamic of how to approach the meningiomas in the future. And I would agree with the comment. Thank you for your contribution. Kamil Hoca, do you have any comments or questions?
There is one more question from
okay, yes, from Crispin, New Vision University. How, as a medical students, can we participate in the study clinical to further our knowledge? It's a good question.
Yeah, so then of course there are multiple options, and sometimes it's more and sometimes less easy. So what we have certainly offered, but to a limited extent, is also that we have international students here as guest researchers or even for an MD thesis or so. But we can also offer to get in touch for possible collaboration projects. And then I think that the options that we have with nanopore sequencing, it will be much, much more widely accessible than the Illumina applications, because it's just so much cheaper. Not the single run of the analysis, but the device. You can even get this even smaller devices, this nanopore flongles, for like, I think 70 or 80 euro or so, depending on the exact market. And that will probably also empower then students to do research in a more wider application area than it's currently possible, when you just have to rely on these very expensive, very rare devices like the large sequencers.
Thank you so much.
And then there's another question, I think, regarding the immunohistochemistry. So what do we recommend for the immunohistochemistry? So first, irrespective of prognosis, but that is already mentioned, we do, as said, SSTR2A and EMA. We also do Ki67 for the proliferation, and in cases that are not clear on the mitotic count, we also do the mitotic marker PHH3, which can also be very useful. But for prognosis, we do not do K27 trimethylation staining, because it is sometimes difficult to evaluate. So it's sometimes not clearly positive or negative. And as we have also heard before from the colleague, it is also very rarely really negative. So there are very, very many cases that you have to test before you find one. And this single case may then be obvious as being high grade anyway, because of mitotic figures or so. So therefore, we do not routinely stain for K27 trimethylation. And we also do not yet, maybe we should do that, but not yet stain for BAP1. And the main reason is that so many cases here undergo methylation, profiling, and sequencing. Therefore, we will anyhow know specifically if there is an alteration, and not only know the immunohistochemistry status. But in cases where we do not do that, or where the material is not sufficient, we then also do the BAP1 staining if we have an indication that this may be rhabdoid or papillary, in which that both can occur, rhabdoid a little bit more frequently, but principally in both. And then indeed we can do this in addition. But both, neither trimethylation nor BAP1, are part of our routine array of stainings for meningioma.
Thank you. Professor Ayçay, do you have any more questions?
Yeah, for the immunohistochemical staining also, there are some papers that recommends P16 staining for CDKN2A deletion in meningiomas, and there are some new papers that recommend MTAP immunohistochemical staining for predicting the CDKN2A deletion. Actually, we do fish analysis for CDKN2A deletion, but there are many laboratories in Turkey that do not have fish infrastructure. So do you have any experience or any suggestion for predicting CDKN2A deletion by immunohistochemistry?
Yeah, so we tried that, in fact, because we were also interested in that, and we did P16 staining. And we did not find it reliable. So there were areas that were stained, but there was deletion, and vice versa. And for example, in MPNST, if you do P16, that is typically very obvious then if there is a loss or not. But in meningioma, it was unclear. And then there was another recent study which we performed together with the Toronto group of Gillare, Sade, and where we performed RNA analysis. And we and they found concurrently that the expression of P16, or the RNA of the P16, increases actually from low to high grade. So there is less in low grade and more in high grade, unless the deletion occurs. Then of course it's gone, right? Then it's negative. But that makes it somehow difficult. So if there are really low grade cases, they have very, very low level of P16. And very low level can then be confused with absence. despite being just a benign one. And that makes it indeed challenging to use the P16 staining as a surrogate for the CDKN2A status in meningiomas. And as that seems to be easier in MPNST, for example, to use this as a marker. The MTAP, that is interesting to mention that because we just discussed that a few weeks ago. A few weeks ago, we were preparing the ANO guideline for molecular testing, which is now published in Neuro-Oncology. And exactly the same question was asked there. So from some colleagues, they said, okay, there is this MTAP. Should we enter this here as a novel marker for CDKN2A alternative testing? And we reviewed the literature, and again, for all these guidelines and classifications and so on, it was not yet enough data, although there is already some, but not yet enough data to really make a strong recommendation. We have not yet established it here. I know of many colleagues who have not yet established that.
How many cases do you have in that study?
We have no study at all, so I'm talking just about others that I read.
Okay, all right.
And we have not stated at all, so we also have no study in this regard. So I have no hands-on experience. I just rely on that what was published, that what I heard from others who have tested it, and it seems very promising. And I could suspect that it will be at least a screening tool, not for ultimate differentiation, but maybe as a screening tool in high throughput settings. But I can really, so there are others who have much more experience on that because I have none, so I can't tell anything. And they are, some of them at least are quite convinced that it is useful.
Okay, thank you very much.
Thank you for your honest response. Thank you very much. I don't see any more questions in the chat. Maybe if someone from the audience would like to ask a question. Kamil Hocam.
I want to thank to Professor Felix Sahm. It has been a high-level informative lecture. I want also to thank everyone who participated to the conference this evening.
Thank you for the invitation. Was very nice. Thank you.
Thank you very much
for your contributions, everyone. Thank you. Have a lovely evening.
Bye.
Bye.